So our final key speaker of the day before Ray closes for us is Kathryn Evans from NHS England. It gives me great pleasure to introduce Kath. She has changed the title of her talk, she tells me, but it continues with the theme that we've seen running through. So, Kath, thank you.
Okay. It's a bit of prerogative, isn't it? You know, last in the day, you're all waiting to go home. So I'll change the title of the presentation just to keep you on your toes. So, I sense a feeling in the room, people are feeling quite weary. So do you want to give yourself a round of applause for actually staying right to the last minute? So give yourself a round of applause for being here. So you've had a long day, and some of you were up dancing late last night. Apparently I missed the conga, so I'm sorry for that. I'm Kathryn Evans, and I'm community nurse lead in NHS England. That's quite frightening. I had to read who I was. Working in NHS England, and I'm a community nurse by background, but I'm passionate about wound care and have been for all my life once I came into nursing. So, as I say, thank you for staying. Some of you will be preparing to get on that train home, and others will be preparing to sit on the motorway. So I do recognise it's a long journey for you. I think for me, the purpose of this presentation is around we're all in it together. So you can see the pandas there. Everybody's working together. We need to work in partnership. So if you're struggling to stay awake because it is warm, just think about, when you wake up at the end, these are the three key messages. One is about teamwork. We need to work together, all of us. We need to work together for the patient, and some of you I don't know whether Andrea showed Betty yesterday. Betty's my pal, and I was fairly horrified when I saw a tweet earlier this year that Betty was promoting flu vaccines. I was thinking, but Betty's mine. She does wound care, she doesn't do flu vaccines. And then I thought that's a bit parochial, really. Betty can do what she wants because she is a patient and she can do exactly what she wants. And now is the time, I genuinely believe, now is the time to make a difference for wound care. You're all passionate in the room, you're experts in your field, and you have been dealing with wounds for years and have been, flying the flag. Nationally, obviously NHS England has picked up about wound care. We've got a real opportunity now. We've got the 5-year forward view and the next steps 5-year forward view. And we really have got an opportunity. So I think everything's come together, the stars are aligned to really make a difference. So how many in the room have seen Leading Change Adding Value? Yep, good. Yep, how many of you read it? Excellent, almost as many. There are a few of these, I've counted them, I've got 9 if anybody wants the commitments in a little card. So if you want one, I've got some to share. So for those that haven't seen, and for those that just need a bit of a refresh, Leading Change Adding Value was launched by Professor Jane Cummins, Chief Nursing Officer for NHS England, and I work in her team. Leading Change Adding Value is the framework for nursing, midwifery and care staff, and it's really important we remember this is for care staff as well. So that's people working in care homes who may not be nurses but are caring for people, and home carers as well. So we need to change the health and wellbeing gap, the care and quality gap, and the funding and efficiency gap. We can't keep continuing the way we have, and we need to reduce unwarranted variation to improve the outcomes for patients, better experience for patients, and better use of resources using the principles of the 6 C's. And that's how we can all lead. This isn't about me, it's not about, the person down in the next team. This is about all of us. We've all got a role in leadership. So you're going to wonder why I'm talking about this, but anyway, these are the 10 commitments which are on the card, and the variety of commitments. It's about working in partnership, it's about delivering high value care. And I think for me, one of the critical things for wound care is about that high value care. We can go out and stick a dressing on lots of different people, but that's not high value. We need to actually work with the patient and heal the wound if that's what that patient wants, because that's what's working for patients. It's not about doing something and going, well, that's a great job, but actually it's not achieving the outcomes. We need to make sure we do that. So the title of the presentation originally was about RightCare, and we're working with the RightCare team. How many of you heard of RightCare? Yeah, a few nods around the room. So the RightCare team developed some packs several years ago now, so Atlas of Variation and Commissioning for Value. And it enables CCGs, so clinical commissioning groups, to look at where they are in comparison to their matched CCGs. So in areas such as diabetes, in heart disease, how they're dealing with hip replacements, people falling. There's a whole raft of information available to them. So they can look at it and start to look at their data in comparison to others. So that's the first box, which is where to look. Then once they've looked at that, well, what do they need to change? And then when they've looked at that, how do they change? What can they change? Working in partnership with clinical leadership, the data, clinical engagement, which is really important, the evidence, and developing effective processes. And that's what we need to do in wound care, isn't it? Some of these facts you all really know well. So we know the cost of managing patients with wounds and their comorbidities is £5.3 billion, same as obesity. We need to raise the profile of wound care. In the guest study, 31% of wounds had no specific diagnosis, underutilisation of diagnostic tests. You know all this. Lack of consistency in care, lack of senior nurse specialist involvement, the cost of the wounds, failure to follow guidelines, and the impact on care and quality. One of the things that wasn't in this study, and some of you may not know, is that 40% of the district nursing workload is on wound care. So if 40% of their work, and you think of the size of the workforce in community nursing, if 40% of their work is wound care, why are we not doing a better job? And that's why I'm here on this stage, because I'm passionate around we need to make a difference and we need to do better. Because we want to reduce that unwarranted variation. We know there's some areas doing really, really well, but we need to make sure that's happening everywhere across the country, every time. Because I wouldn't accept it for my parents, and I don't think you'd accept it for yours. We need to make it right. But we know the system is really, really complex, don't we? It's not easy out there. There's so many different conflicting priorities. As I walked into the exhibition area downstairs, I just thought you can become overwhelmed by the different products that are out there, the different things that you can use. It's a minefield. And our role is to help our commissioners. How can they possibly understand what needs to happen for wound care? Because if you think of all the expertise downstairs in the exhibition and all the things that they're promoting and selling, that's fantastic. But how would you as a commissioner be able to say, okay, so what do we need to do about wound care? But we need to work together to help with this complexity and try and make it simpler. So last year, NHS England launched a national programme on wound care, following the launch of the Leading Change Adding Value framework. And wound care fits really well with Leading Change Adding Value. And I apologise to any AHPs, podiatrists, OTs in the room, but largely wound care is dealt with by nurses. So it's an area where we can really lead on and should lead on, and we can really demonstrate some outcomes. So using the RightCare principles, we've set up this piece of work. Using the economic study, an expert reference group was set up, and some of the people in the room were actually on that group. And we developed a project plan and some work streams about what needed to happen to start to make a difference, because we needed to do something which we could lead on nationally, that brings things together to support you who are out there delivering the care. And then we developed some interest groups for each work stream. So some of the pieces of work that have been delivered as part of that work stream, so bearing in mind we only started in April last year, one of the first pieces of work was the national sequin for wound assessments for community providers. Has hands up if you've seen it? Yeah, quite a few of you, great. It is available on the website. So that's around setting a baseline or assessing where your community teams are on wound assessment, and then setting a trajectory on where you want to get to, and it's a 2-year sequence. So we've achieved that, and I've put the little glittery bits at the bottom. just in case people get a bit worried about what sequins are. It isn't the little sequins you sew on your dresses. The other piece of work which is linked to that, and this has been led by Suzanne Coleman from Leeds University, was the wound assessment tool, which is developed through the consensus approach. And I think, did somebody speak about this yesterday? Yeah. So those that were here yesterday should have spoken to this. So I'm not going to go over that in any way. But that's out now, and if people haven't got the link to it, if you approach me at the end, I'll be able to send you some details. And then the other piece of work is Betty, who Andrea presented yesterday, the economic case. And again, Betty demonstrates what optimal care could be like and what suboptimal care is like for a person with leg ulcer. And it's not an unfamiliar story, because wherever I've gone and I've talked about Betty, and nobody's yet thrown a tomato at me. This first time for everything, but it seems to be sort of like saying what's happening out in the field, which we need to improve on that. And in there was some data which demonstrate to commissioners the opportunities that they've got. Another piece of work is the React to Red. This started in Bassett Law and with care homes, and I heard a really compelling story from a CCG nurse who was saying, we've got patients who live in care homes, and for the Bassett Law area, that was 1,000 patients. She said, why wouldn't we look at the quality of care in a district general hospital of 1,000 patients? We wouldn't ignore the quality of care for those patients. So why would we ignore the quality of care for patients in care homes if you've got 1,000 patients in those beds? And that really resonated with me. She said, we don't ignore the quality of care of patients in GP practices. They're private businesses, but we're interested. So React to Red is a really powerful tool, and they've demonstrated some really positive results as part of that. So what are we doing next? So that's what we've done in year one, and we haven't done that alone, I can assure you, because we couldn't do it alone. We've done that in partnership with some key people around this room and others that aren't here, because this isn't about us NHS England doing it all or doing it to you. This is about a partnership approach. So the next steps are about the evaluation of the React to Red pilot sites. Just get onto my notes on this. Yeah, so they achieved an 87% reduction between 2013 and 2016 on reducing pressure ulcers, which is a fairly impressive result, I think. So for years 2 and 3, what are we doing? Completing the evaluation, developing a good practice guide for lower leg wounds, and you heard about that yesterday. Piece of work I'm leading on is about the commissioning resources for wound care, and I'll talk a little bit about that in a minute. An education and competency guidance, which has been developed. And one of the areas that's been looked at about that is an apprenticeship model for wound care, which I think is a real opportunity to try and move people from generalist to specialist role. So I'm really looking forward to seeing that develop over time. So in terms of a commissioning resource, as I say, if you're a commissioner, you've got all these services that you commission. What do you pick to look at and spend more time on? So last year I was talking to practice nurses and district nurses, and they were explaining to me what it's like out in the field around particularly practice nurses saying, sometimes the commissioners change the specifications for district nurses to say that district nurses now only see housebound patients. So walking wounded and people with wounds now go and see the practice nurse, but actually the practice nurse may not have had the education, training and skills to deal with those wounds. May not have the time because she's got 10 minutes. She may have 10-minute appointments and already has a busy caseload with long-term conditions, diabetes checks. So in terms of their priorities, it may not be a high priority. For the district nurses, they talked about the housebound patients and the ability to access care and the and the resources that they have, and being able to use the Doppler machines, be able to get them, go out, take photos of wounds. So there's a whole raft of issues that those nurses described. But what they eventually said is actually wound care is everybody's responsibility, but nobody takes the accountability to sort it all out. And actually that's a real opportunity. So we pulled together a group of commissioners and some experts in the field and said, so what is going to make commissioners look up and take notice? What do they need to do to help change the wound care environment? So, and this is literally what they came up with. They needed data that was population specific to them. And the new care models teams actually provided me with a presentation and said, is this about looking at wound care, or actually is it what are the conditions that you might want to avoid, get into that prevention? So I was talking to Peter Vowden, one of the researchers, and saying, so what's some of the evidence about, you know, what's happening in terms of prevention? And he was saying that people who don't have central heating, their wounds take longer to heal. Well, I didn't know that. So, you know, if you're looking at stuff like social deprivation and people who haven't got central heating and the warm housing schemes, actually there's a real opportunity to look at how we could perhaps maybe get into prevention or better healing. Need to provide compelling evidence for change, and that might be using the Betty story as evidence for change. Providing evidence, what's broken, what isn't working. Talk to the commissioners about what's working. If 40% of the district nursing workload is on wound care, then we should be doing something. Providing that story. Looking at incidence and prevalence about what's happening on wound care in each patch, presenting that to the commissioners, and the opportunity that affords. Looking at referral to healing time. And I know this is quite controversial with tissue viability nurses, but it may be that is something we need to be demonstrating, even if it's about providing a benchmark and saying, so why is it district nursing team X or practice nurse team Y, what is their healing rate? Is there a difference in the population? Is there a difference in the care? To start asking those questions. What's going on under the radar? So I know when I was a district nurse, which was quite a few years back, we had dressings in the boots, and you went out and you put on the dressings from your boot, and then when the patients no longer needed it, you put it back in your boot. Can't do that anymore for a whole variety of reasons. But we know there's a lot of waste. So you will have district nurses in the room saying, no, none of us are doing it. But I can bet you bottom dollar that's still going on because we hate waste. Nobody likes waste. So what else is happening under the radar? Are the Dopplers not being done because actually there's only one Doppler machine for 5 teams and they can't get access to it or they can't take photographs? But we might say, yeah, we've got Doppler machines, we've got cameras, we need to make sure we're doing it well. Looking at what's part of the patient's experience, what's happening locally. Are patients getting a good outcome? We know patients who are over the age of 85 tend to rate services more positively than any other user, because actually they're really grateful for the care they get. But actually, what is really happening for them? Are they getting the care they need? Levels of competency, have the staff got the right expertise and skills? And understand the care pathways for those that fall out of it. Actually, not everybody wants the nurse to come in and do the dressing. You know, they want to be self-caring, and it's great to hear what Kim was saying about self-care. And we've got a patient on our expert group who was saying, I want to debride my own wound. I don't want to wait for anybody to come in. I work full-time. I want to work. Actually, I need to be in control of my wound. And then obviously CCGs want product and pricing data. So that group came up with some pledges, and these are only some of the pledges. So the Pacific team, so they're part of the BSA, they're looking at developing 2 case studies using a non-FP10 wound care product and looking at putting it into a RightCare casebook format. They're also going to look at data that can be available from the BSA about what's been prescribed using EPAC2, so they're looking at how they can do that. And what we're wanting to do is put all these resources onto a website so that commissioners can look at it in a way that's easy for them to say, right, okay, I can see what I might be able to, what opportunities might be available to me. The Carter team, so for those that aren't aware, so there's efficiency and work done within the Acute Trust last year. That's now started in community and mental health teams, started in a couple of weeks back. Real opportunity around wound care, and there's a lady called Anne Jacqueline who's looking at medicines optimisation, about what we can do better. So she said this isn't about, this is the cheapest dressing. What she's saying is what is the best use. The cheapest dressing may not be the best thing if nurses have to then visit 3 or 4 times a day to dress a wound. Some of the other pledges from people in the room was about let's agree some read codes that we can use. So read codes are when you write in sort of like the patient record that's linked to the GP caseload, that you can then pull information from. So there's a group of people who are starting to look at read codes, and also looking at GP engagement. So I'm here to ask for your help as well. You didn't think you'd get out of the room without asking for help, because this is about a partnership approach. I am not the expert in wound care. My role is to bring things together so that we've got things in one place so that we can raise the national profile of wounds. So what I'm looking for to put on for a commissioning resource is examples of support for patients, for example, self-care, leaflets on how to recognise infection. So one of our patient, Andy Lavender, he was saying, she says, why don't we have a formulary for patients which explains about the dressings? So it says, this is a particular dressing, these are the side effects, these are the when you would use it, this is how long you should use it. So actually they're a bit more in control, so they can actually negotiate with the clinician that's prescribing that care to say, actually, this doesn't work for me, or, we shouldn't be using this any longer because I've had it on for however long. So any examples of support that support patients. Any service specifications, and particularly, is there anything in the diabetic specifications which link to wound care, or are they treated as 2 separate pathways? There's an opportunity there. Technology for Doppler assessments. So we know that patients have to lie down before the nurse comes or whoever's doing the Doppler assessment, and it takes time and organisation. Is there a way of improving that? I remember sort of like a few years back we used Doppler Assist. Is anybody using some really good technology or a good way of making sure everybody gets the Doppler that they need at the right time? Changing culture so that actually it's a referral to the team for success. So wherever you're having your wound care, you're expecting, what's going to happen. This wound is going to heal within whatever length of time. These are our expectations. How are we articulating that to patients? Are we saying, right, I've come to see you, whatever it is, I anticipate this will be healed in X length of time. We expect that with hip replacements. We expect that with lots of different care. Why are we not doing that with wounds, or even starting to make an attempt on that? GP engagement's really important. Because if practice nurses are doing a lot of the wound care, we need to make sure that GPs are engaged. Has anybody got a good case study where GPs have been really engaged with wound care to improve outcomes? And then, and I've mentioned the patient formula. So if there's any examples, please email me, and then we can see what we can put on the website. What I don't want to do is swamp commissioners with loads of information, but put some key things on. So moving on, plan for year 2 and 3 as part of this programme is about increasing wider communication and sharing. I think this is a great opportunity to do that. Developing greater patient feedback and engagement in our work. So if you've got any patient engagement groups, please let us know, or you can feed insight from patients into our work. That would be fantastic. Evaluation, so there's going to be some more evaluation of React to Red. Wider project evaluation of the whole workload, and around developing pilot sites for good practice in wound care and pilot sites for leg wounds and commissioning guidance. So, another question. How many of you have read the next steps on the 5-year forward view that came out last Friday? I can't believe it. If you hadn't been partying last night, you could have read it, couldn't you? So for those that haven't read it, there's some key areas in here. It's a real opportunity to move forward. So something about urgent and emergency care, and for most of you it won't have escaped you, the pressures in the system, and we recognise that. We've got an opportunity within wound care to think about that, because we've got patients that are going into hospital with leg ulcers as their primary reason for going in. What can we do to reduce that? There's unwarranted variation in that, or it appears there is unwarranted variation. What can we do? How can we improve wound care so we can prevent some of these people going into hospital and making sure that they come out quickly? About integrating care locally, you've got the new care models, there's sustainability and transformation partnerships. There's some real opportunities. What can we do on a STP footprint, a sustainability and transformation footprint? What can we do? How could you set up services differently about a bigger footprint to get better outcomes for patients? How are we engaging with the community? Really engaging with them to self-care. So we know about the Lindsay Leg Clubs, a real opportunity, but there's other models. How can we use the community to empower people? And then there's accountable care systems, which is again working on a bigger footprint. How can we work together? So you see the change in language. This isn't about us working against each other. This is about partnership and the systems working together. Funding and efficiency is one of the key areas in the 5-year forward view, the next steps. We know we've got some real opportunities with wound care to make better outcomes for patients, better experience and better use of funding and resource. So use that Betty scenario to have those challenging conversations. Patient safety. So when is it a patient safety issue that we're actually not addressing wounds in a way that we would want to, or wound care isn't as good as we would want it to? Because actually, we talk about safeguarding, we talk about safeguarding in pressure ulcers. When is it safeguarding in terms of a leg ulcer or any other wound care? And then harnessing technology and innovation. What a fantastic opportunity we've got with this. There's loads of innovation in wound care, but there's so much. How do you work your way through that? But, as I say about the Dopplers, is there an opportunity there? Is there some magical tool? You're the experts, So what I challenge you to do is use this to help drive change with wound care and inform commissioners. As I said when I started this speech, this presentation, I think now is the time. Jane Cummings, Chief Nursing Officer for England, knows about the work we're doing and is really keen to hear about the progress we make on it. The work is being led by Margaret Kitchen. She's Chief Nurse for the North region in NHS England, and she's a tissue viability nurse by background and still practices 1 day a week. So she's really passionate. I can see Jane nodding. So let's work together. This isn't about us or you, it's about all of us together making the best for the patients we care for. Because at the end of the day, we're doing it for Betty and all the other Bettys and Bill, I'll just rename him, Bill, and that's what we're here for. So thank you for listening. If you want to follow, you can follow me on Twitter, but I've not put my Twitter email thing there. But anyway, you've got my email address. And you can follow Lead to Add, which is the Leading Change Adding Value.
Lovely. Thank you, Kath. I think when I opened yesterday, I opened with, is it our time? And you've answered that by saying now is our time, and I think that's quite nicely closed the circle for the whole conference without us communicating about that. So
yeah, that's quite impressive, isn't it?
Yeah. Does anybody have a question for Kath? Surely we've got some. I should be able to think of one, but I'm so involved.
It's okay, I'm happy to be let off lightly.
Yeah, so involved in the work that you kind of lose your questioning head about it. No questions for Kath. It's a valuable person in the room for us, yeah?
You've got my email address. You can
Yeah.
always email me if something occurs
Oh,
to you
somebody's
later.
got one over there. Sorry, we've
sorry.
got... Oh, look, you can't escape that quickly.
It's not a question really, other than just I work in a care home. I work in a company that has 16 care homes in Cornwall, and I did used to work in the NHS, and it really highlights, I think, sometimes what you were saying about ignoring quite a large part of, you know, that care provision. And it is quite hard, really, if I'm not working for a company like mine who is happy to send me on these TVS dates. You know, it's... I sometimes think that we really are the sort of Cinderella, and that everybody just thinks we're money-grabbing, you know, abusers. And of course we're not, by any stretch of the imagination. There's a number of people who work extremely hard to try and get the best possible care for the clients that they look after. And I think we ought to try and recognise that more, really.
Yeah. No, I would agree. And NHS England's doing a piece of work with the independent care sector, particularly with care homes and home care, not specifically on wound care, but generally about embracing them into healthcare. So they've got some regional leads who are working with the care sector forums to try and get care homes linked in more with CCGs and what's happening there, particularly around the urgent care agenda, to sort of like stop people going into hospital. And obviously there's the care home vanguards and the rollout of that over the coming months and years. So I think, you know, I hope to see the tide changing on that.
Thank you. Any more questions?
Anybody want a card? I'll leave them on the front.
Thank you, Kath.